Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from India, Dr. Rupam Borgohain. Prof. Borgohain is the chairman of the Parkinson's Disease Movement Disorders Research Center, Yashoda, High Tech City, Hyderabad, India. He was the former professor and head in the Department of Neurology at the NIMS, Hyderabad. He started and established the Movement Disorders program in NIMS, and his passion for DBS is well known. And he has not only made NIMS a large output center but has inspired many and helped to start neuromodulation at various centers in India and Sri Lanka. Currently, his center predominantly focuses on movement disorders with more than 100 DBS over the last 1.5 years. He is also a noted author with more than 150 scientific publications in various peer-reviewed national and international journals. He is the founding member of the Movement Disorder Society of India and was the former president of the MDSI in 2021-22. And we are extremely honored to have him today at our webinars, and today we will be talking about current status of STN DBS in Parkinson's disease. The speaker for the second session of today is our honorable guest from Israel, Prof. Shlomi Konstantini. Prof. Konstantini has been the director in the Department of Pediatric Neurosurgery at the Dana Children's Hospital, and he is also director of the Israeli International Neurofibromatosis Center. He has received his training from Fred Epstein NYU, specializing in complex brain and spinal cord surgical challenges in children, focusing on those that are more difficult to operate. He is an active internationally while serving his roles in global organizations such as IFNE, ISPN. He was the past president of the ISPN and past vice president of the EANS. He has published over 300 papers in peer-reviewed journals and over 50 book chapters. We are extremely honored to have him today at our webinars, and today we will be talking about pediatric ependymomas. The chair for the first session of today's webinar is an honorable guest from Saudi Arabia, Prof. Ahmed Al Khani. Prof. Al Khani is the head of neurosurgery at the King Abdul Aziz Medical City, Ministry of National Guard Health Affairs, Riyadh, and he is also the professor at the Al Faisal University. He is the head of the Scientific Council for Saudi Board in Neurosurgery and also the president of the Pan-Arab Neurosurgical Society. He currently serves as chairman of the Stereotactic and Functional Neurosurgery Committee of the World Federation of Neurosurgical Societies. He is an invited faculty to several conferences around the world, and we are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chair, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over this online podium to our honorable chair, Prof. Ahmed Al Khani.
Well, thank you very much, Raja. That was wonderful. It's our pleasure today with the early days of spring in Riyadh. It's a bit hot though. That we are going to have the Asian Congress of Neurological Society webinar series. Today we have like two diverse topics, but the first topic will be more into stereotactic functional neurosurgery. We are honored here to have Professor Rupam Borgohain, who is the former professor and head of neurology, chairman of the Parkinson's disease and movement disorders in High Tech City, Hyderabad. So we have a big figure. He's going to talk to us about deep brain stimulation for the subthalamic nucleus as a treatment of Parkinson's disease. We are all eager to hear from him. What's the new update, how things started, and where we are going in the early future, in the next 5 or 10 years. Professor Rupam, we are all here waiting to hear from you and to learn more about DBS for subthalamic nucleus in Parkinson's disease. Professor, the podium is yours.
Thank you. Thank you, sir. And I really appreciate the ACNS for asking me to give this talk. Thank you very much for those kind words. We started DBS here in our center in 2000. At that time, there were very few of us, and now there's a very strong passion for DBS. These are actually 6 movement disorders specialists in the operation theater with 1 neurosurgeon there. In most centers, it's difficult to get 1. Here we have 6, because all of us are very convinced that DBS is the way to go as far as Parkinson's disease is concerned. This is a video of a patient who was operated in 2001, and this video was actually taken in 2003. He had Parkinson's disease for 13 years. And you can see from the video that it's the effect on tremor is very remarkable. You can see that now he has no tremor. Put off the battery, and immediately the tremor comes within 5 seconds or so. Another 5 or 10 seconds, the tremor becomes very severe and very intense. This is possibly one of the more incapacitating tremors that you see in a patient with Parkinson's disease. It's present at rest and present very, very severely. Some of these tremors can be totally unresponsive or very little response to dopaminergic agonists and levodopa. And these are the patients we need to do surgery early. Here it was done quite well. And subsequently, when we put on the same pacemaker, you can see the remarkable results. The tremor subsides instantaneously, and it's quite remarkable. Not all patients have such a remarkable response, but most of them, you can get a very good response to tremor in cases of Parkinson's disease. This is a video of a senior psychiatrist who was operated as late as November last year, and within 3 months, his son writes to me. He's a vascular surgeon in UK, and he writes to me that he's much better than before. He's putting his cell phone in the do not disturb mode, and now I'm not able to access my father. But this is not a difficult problem because he's so much more into his work. So that's what makes us very, very excited about DBS. You can get them back to their work. This is a patient who was operated 35 years back. Sorry, 20 years back. He was 30. This is in 2003. And this man, you can see in the off, he was very bad. In the on, he was much better. But still, the ons were very little. Offs were much most of the time. This is him after surgery. The off was better. And the on, he was very good. So this man was on just one tablet of levodopa. This is the same patient some 7 years after surgery in the off stage. And this is him some 21 years after surgery in the off stage. He's on just a single tablet of levodopa. And with this, he's working even now as an auditor in the government finance department. So it's quite remarkable that you can give a full functional 21 years of life to a patient with young onset Parkinson's who was very severely handicapped. So who were the persons who brought about this remarkable therapy to us? It was these three giants: Benabid on the right, Pierre Polak on the left, and Benazuz, the neurophysiologist, on the left, in the center. So these three are seen here. This is a ceremony that they had just 2 years ago in Grenoble when we celebrated 30 years of the first successful DBS of the STN for Parkinson's disease. This has brought about such a remarkable improvement in the quality of life of Parkinson's disease, which is the second most common neurodegenerative disorder that we have. The key to this is a multidisciplinary approach, and we need to learn to work as a team. The FDA has approved Parkinson's essential tremor and dystonia for tremor as well as treatment, and is also approved for focal onset seizures, OCD, pain, and depression. Others, because of the improvement that we see in these diseases, there has been a large effort worldwide to try it in various disorders such as epilepsies, such as psychiatric depressions, such as PTSD, impulse control disorders. It's also been used in vegetative disorders and Alzheimer's disease. This is only because of the massive therapeutic effect that you see in Parkinson's disease. What's the benefit? This benefit is as very evident, continues for beyond 15 years from the time of intervention. It's also seen in we can use it in advanced Parkinson's disease, but you can also use it in early PD once you have motor fluctuations. How does it work? This is the mechanism, the pathway that we see. The pathway is basically that the GPI or the STN, both of them actually, in this case, you can see this, the dopamine deficiency causes the striatum to be disinhibited. This leads to an inhibition of the GPI or of the STN, and they actually overfire. And because this firing down the way, the motor thalamus is inhibited and the output from the motor thalamus is reduced, leading to a hypokinetic pathway. Now, if you really want to fix patients with Parkinson's disease, the target is the STN or the GPI, both of which the overactive discharges that you're seeing gets normalized. This is how it works. This is basically because of the increased inhibition caused in the GABAergic pathways are reduced by taking out these overactive nuclei. What are the possible mechanisms that lead to this? There are three possible mechanisms. One is amongst the many that are described. There are some that can be inhibitory responses during DBSs causing a depolarized block or an inactivation of the voltage gated pathways or an activation of the inhibitory effluents. These are the three common ones. Others which have been seen include effects on the blood-brain barrier and effects in the microenvironment effects on the non-neuronal cells. Neurotransmitter release has also been described in these patients, and that's how we believe the DBS works. We are really not sure 100%, but we think these are the various pathways in which this works. What's the current status? The current status as of today, which I'll be coming back to again, are the recommendations of the European Academy of Neurology and the Movement Disorder Society, the European section. What is without doubt is that in advanced Parkinson's disease with resistant fluctuations is that you should recommend for eligible patients DBS of the subthalamic nucleus. If they do not have fluctuations, do not do DBS. What about others? You can look at things like DBS of the GPI. You can do the levodopa, carbidopa infusional gel, apomorphine infusion. All of these can be considered to offer, but nothing matches the efficacy of the DBS subthalamic nucleus, as you will see further on. Focused ultrasound, which we hear so much about, is actually used only in unilateral symptom patients, Parkinson's disease with unilateral symptoms. So this is just again to share the timeline from where we went. 1952, Delgado described the technique of DBS electrodes, and 60s we went into chronic stimulation. Then it was basically around 1980 that Cooper and went around using stimulation in the management of movement disorders. And the final change, the most important breakthrough, was by Benabit Pollock and their team from Grenoble in 1987, when they first used it in thalamic stimulation for tremor. Then they also used it along with limousine, was used in the efficacy of bilateral STN in DBS in 1998. So this was the team that actually discovered and basically invented all this. Other than this, subsequently we had approval by the FDA for Parkinson's disease in 2002, dystonia in 2003, OCD in 2009, and epilepsy in 2017. So this is how the whole timeline has been, how this has evolved with time. All of us are familiar with this, the fixing of the stereotactic frame, taking the patient to the MRI, and planning. In our center, we do targeting in two ways. We, the neurologists, actually cross-check everything on the MRI console, plan it, while the surgeon does it in his stealth station or brain lab. And we correlate with each other and make sure that the targeting is proper. This does reduce the number of targetable errors. Other things that you can look at is all this that we have not used so much in our system is connectomic targeting. Intraoperatively, the surgeon does the main thing, which is getting the electrodes in the right place, while we, the neurologists, work together to look at the anatomical localization, to look at the physiological mapping, which is most important, because we are strong believers in awake DBS. We do not use asleep DBS except in patients who have very severe dystonia and dystonic movements, where it may not be possible to do this. So what are the methods that we use? We use the intraoperative MER, which was initially introduced long back in 1921, and the single electrodes were used, very small ones. We use a bend gun technique. Initially, we were doing 5 electrodes simultaneously. Now we use only 3 to reduce the risk of hemorrhage. And the MER activity, which is a neural activity, is seen in the computer screen. And this can be seen like this, as you can see here. This is the MER activity. Once you hit the subthalamic nucleus, there is an increase in the burst and firing, and the channels, you can see the bursting and firing pattern. And this can be seen whichever system of MER that you use. This is standard treatment for Parkinson's disease everywhere. This is when you reach the STN and you go into the SNR. Regular firing with a narrow baseline with a regular firing. This is the standard firing that we see in the substantia nuclei reticulus. So you can look at various methods of looking at this raw data. You can use the histogram frequency. You can use other things like the fast Fourier transformation of these and reach the same conclusions that you use by looking at the basic data. The other way of localizing your activity is to look at the local field potentials. These are basically low frequency recordings which contain about 1,000 units, around about 1,000 neurons firing around the recording electrode. The MUA, which is the multi-unit activity, which has more than 1,000, which is high frequency portion of the recording, represents the spiking. While we use the predominantly the single unit potential recording that we see here. This is to make sure we are in the right place. You can see the single unit being triggered out. The local field potentials, as I said, around 1,000 units neurons are recorded at this time. They help to determine the network rhythms. And you can look at the cellular and synaptic cellular architecture and the synchrony between the current sources. This is just to give an idea. LFPs are basically characterized into various bands, and this is important for us as neurologists because it's the beta band, the low beta, which has been of the 12 to 20 hertz frequency, which has been used for the Percept PC to record and give a feedback for what we are now trying to evolve into our neuromodulation. This is associated with muscle contractions that happen in isotonic movements, and they are suppressed prior to and during movement disorders. So you can see the low beta and the high beta here. And this is the gamma, which is actually associated with the large-scale brain network activity and the cognitive phenomena. Basically, this has been more associated with the dyskinetic movements that we see in patients with Parkinson's disease. The high-frequency oscillations are also there, and they are not used so much as in DBS as are these two. So the main two LFP frequency bands that we are concerned with are the low beta, where we see predominantly in about 70% of the akinetic rigid states, and also the gamma, which we can see in the range of 60 to 90 hertz. And this is seen in both the tonic phase and the tonic and phasic elements of the dystonic contractions. This is a potential association in the gamma, while that is the likely association in case of low beta. Why is this important? Is that we can use this to localize even in case of the DBS on table. We can localize the best site to record and best site to implant that we do using the MER. So this implantation track can be used by local field potentials also. What about DBS? The third most important part on the table is actually stimulating a patient. This is a patient with actually essential tremor, but just to give an example, as you can see, this is how he is before the stimulator is turned on the table. And this is the patient after the electricity is turned on in the brain, and you can see that the tremor is suppressed wonderfully on the table. This can be quite remarkable, and the response can be quite impressive. In Parkinson's disease, what do we look for in the table? We look for four things. We look for the rigidity. We look for the akinesia, the speed of movements. We look for the tremor. And the fourth thing that we look for is actually the dyskinetic movements. The dyskinetic movements tells us that we are in the subthalamic nucleus, and it's the target of choice. So we also look at higher currents for the side effects. The side effects are spread to the associated pyramidal tract, they're spread to the corticobulbar tract, and the fact that the voice volume can drop. And also we look at the eye movements. The gaze deviates to one side is because of corticobulbar fibers. If it's only one eye moving, it's because of the third nerve involvement. We also look at the sensory sensory involvement, which is basically indicating that you're either too medial or too posterior. Keeping all this in mind, the improvement as well as the side effects, we can see which is the best track to choose. And that is the target we localize in. What's happening, which is new, is that the sweet spot, if you are far away, you can use directional leads. And these directional leads, unlike the ring electrodes of the past, are split into multiple segments. So you can actually direct your output and actually target it towards the sweet spot and try to stay away from the SARS spot, which is causing the side effects. This is if you are not in the right place. If you are in the right place, by and large, you don't need to use directional leads. These are the currently available leads. As you can see in the Boston Scientific Versailles, it's up to 8 electrodes, contacts. They also have segmented leads, as does the Medtronic Sensite have. And the Medtronic standard one actually has 4 electrodes, which is maybe closely spaced about 0.5 millimeters apart or about 1.5 millimeters apart. So you can choose your electrode. You can then have different systems depending on what you want. The two most common ones are, of course, Medtronic and the Boston Scientific, with Abbott being the third. What about the impact? The most significant impact is on the akinesia, though if you're in the STN DBS, and the rigidity. The rigidity is impacted equally in the GPI as well in the STN, but actually the akinesia is affected much better with the STN. So today, the STN DBS, though it's more difficult to do, more difficult to target, more difficult to program, is the treatment target of choice in Parkinson's disease worldwide. Some people still persist with treating the GPI DBS, but the problem with the GPI DBS is that your effect on akinesia is less, and you are not able to reduce the medications post-op. That's why worldwide today, which you can do very well, you can reduce the medicines by at least 50% in case of STN DBS, if not more. That reduces a lot of the post-DBS confusion, the cognitive slowing, the hallucinations, just by reducing the medicines and the dyskinesia. So STN DBS is the treatment of choice by far. So while dyskinesia itself per se, the effect may be more of the GPI DBS, it is the STN DBS is still the treatment of choice because you can reduce the dyskinesias by reducing the medicines that you use. So what has happened now is that we've spent the last 20 years following the CAPSID protocol, which was very rigid. If you had any imaging criteria, any abnormalities, you were supposed to avoid doing DBS. Any cognitive impairment, we used to avoid DBS in the CAPSID protocol. The liver depot challenge test was very rigid, and with that only you were able to do the surgeries initially. Anybody who had axial symptoms, gait symptoms, swallowing, speech difficulties, you're supposed to avoid. More than any mild clinically cognitive impairment, you would need to avoid. But now what has happened in the last 20 years is that a lot of new things have come in. We've started looking at patient-centered outcome measures. We have been able to take on patients with axial symptoms like a gait involvement to a certain extent, speech and swallowing difficulties to a certain extent. Genetics has added a whole new chapter in the treatment of DBS, though they are still not determining, while we can prognosticate after the DBS, it is not really ruling out the entire treatment. It is just not giving any indications per se, but it does serve as a guidance to tell us what the outcome could be. Behavioral symptoms per se have been better managed now. We are actually able to take up patients who were previously a no-go such as severe hallucinations, control the hallucinations first and then go for surgery. Non-motor symptoms have become and have helped to act as an add-on to doing surgery. Early DBS is where things have changed dramatically. Initially, patients were taken 7 to 10 years after surgery. Now we take them as early as 4 years after surgery. And especially the younger patients we take up, if they have a 50% improvement in the levodopa challenge test, this includes the axial signs. So things have changed dramatically. The spectrum of patients that we take are much broader and the results are much better because a lot of things have changed in targeting also. This was an 83-year-old gentleman who had very severe hypotension before surgery. Even a little bit of levodopa, and he would get these attacks of syncope, which while sitting down, he would get an attack, and from which he would recover spontaneously. This is on small doses of levodopa. So we offered him DBS, saying that we could bring down the levodopa effect by reducing the levodopa dose post surgery, and he agreed to that. We did his surgery, and he is much better now. Bilateral STN DBS was done. He is on just half a tablet TID of levodopa, carbidopa, and also on midogreen, 2.5 mg. And he is able to carry out his day-to-day activities, function well. So this is a patient where you would not have dreamt of doing DBS at the age of 83 before. You would not have taken him up because he's already developed hypotension, which would have been considered a contraindication. And today we are able to do this and have good outcomes because we are able to face these challenges quite successfully. This is the other side. This was a young boy, 26 years of age. He joined his MD in radiology, and the next day he came for DBS because he had a genetic induced Parkinsonism. And because he had actually, with that genetic Parkinson's, he was told that he can undergo DBS, and we got his DBS done very early, and he's continuing his residency. He's in the second year of his residency now because it was done 1.5 years ago. So what was the study which made us change this from doing DBS late to early? It was the early STIM study. This was a path-breaking study which was published in 2014. And what did it do? It actually took up patients into two different arms, those who had only STN DBS and those who had the best medical treatment along with without STN DBS. So both the patients were rigorously monitored. The medical arm was monitored strictly to make sure they got the best medical therapy, and it was not a slipshod affair. These patients were monitored and checked. After 24 months, what was seen that was that the UPDRS3, both for with the medicines and without the medicines, while on stimulation, the patients were much better. The mobility was much better in patients who underwent DBS, the blue line that is. The bad mobility was reduced in the patients who had DBS. The dyskinesias were less. The levodopa equivalent dose was less. All the Heen and Yaar was better in patients who underwent DBS. The walking test was better, as was the UPDRS4. So the only point in the entire thing was that the adverse events because of falls are more in DBS patients. But other than that, in every criteria that you monitored was measured, the STN DBS patients did much better. So this study was such a pivotal trial and well done that it showed very clearly that STN DBS patient fared better. Because of this, early DBS was approved by the FDA within 4 years of onset of the disease, with about 2 to 3 months of fluctuations. The problem of doing early DBS was that there was some doubt as to whether you would be including patients with Parkinson's plus. But this was the less than 0.5% of the patients who developed or who underwent this actually turned out to be Parkinson's plus. So since the numbers were low, and you could really rule out Parkinson's plus by looking at an excellent response for levodopa more than 50% and presence of most motor complications without any cognitive deficits and no major comorbidities, no major depression, no neurosurgical contraindications, these patients were taken up for surgery and have been taken up since then. Why is this necessary? Because we need to get the patients back to a functional stage. There is no point treating patients when they're far gone and you get them back a little bit. It is better to do it earlier, give them a long functional 15, 20 years of life. These are the contraindications, specific challenges that have to be considered when early STN DBS is concerned. As I said, patients with atypical Parkinsonism, and whether it may be unnecessary with a mild course of PD, and you may have to live longer with the implanted device. All these have been looked at it. And you also look at multidisciplinary care, especially to look at the suicidal behavior, which may not be available elsewhere. This is an example of a patient who underwent DBS at the age of 41. He had Parkinson's disease for 7 years. He's a lawyer, and this was his condition when he actually came. Most of the time, he used to be off. He could not walk unsupported. He had a very severe tremor and was very rigid. He was on for about 2 hours a day, and during the on time, he was very fine. So his on-off was very good. And because of this, we took him up for surgery. This is in 2004. This is him 6 weeks after surgery. And what was the most remarkable feature is that in DBS is that the off becomes much better. This is him without medicines. And as you can see, he's much better now, except that the tremor was there initially. And this also subsided later on. This is the same patient 9 years after surgery. This is him 14 years after surgery. This is him 18 years after surgery. And this is him 20 years after surgery. He's still on very little meds and has undergone 2 battery changes. Some amount of dyskinesia is there. Other than that, he's fine. So, what is the question of survival in DBS? There is a little controversial because there have been quite a few studies saying that there is no change in survival, but there are other studies which show that patients undergoing STN DBS live significantly longer, maybe about 7 to 8 years longer. As you can see in the patient with the blue line here, those are the ones who have undergone DBS, while those with medically managed patients usually succumb earlier. What is for sure is the complications of long-term Parkinson's disease, which includes hallucinations, which includes dementia, which includes hospitalization into nursing homes, and death occur later in patients with Parkinson's disease undergoing STN DBS. The persistence of the long-term outcomes you can see in the way that the time spent with dyskinesias is markedly reduced by 1 year and also the time spent in the off state is markedly reduced by 1 year. And this more or less persists in a flat line, except that there is some worsening in the off state over 15 years. But it is still much better than at baseline as compared to the baseline. So this reduction is as much as 75% and 58.7%. It is very remarkable about this. As you can see, they maintain an improvement in quality of life also. Now, what is the updated criteria for doing DBS in Parkinson's disease today is that this was published in 24, is that you have one indication and all 5 prerequisites. This was proposed by Barbosa et al. And what did they say? The 3 indications are motor complications, refractory tremor to optimize therapy, and intolerance to dopaminergic agonists. Of the motor complications, the 5-to-1 criteria has become very, very important. This is actually being proposed by the Delphi criteria, and this is like this, that you must have, if you are receiving either 5 tablets of levodopa, or you have 2 hours of off, or 1 hour of dyskinesia, that is a complication good enough to take up the patient for surgery. The prerequisites are that you must have Parkinson's disease, exclude all Parkinson's plus. You must have more than 4 years of disease, must have a cutoff of 33% in the levodopa challenge test, and absence of significant cognitive or uncontrolled disease. And they must be able to come for follow-ups. These are the ideal patients to treat: tremor dominant, levodopa responsive, moderate stage, good STN GPR functional connectivity, less than 70 years, no bad out genetic variants, no cortical atrophy, good levodopa response, and with good support. And this is when you need to be a little careful when they're older than 70, they have axial symptoms, some poor genetic variants, mild cortical atrophy, or a poor levodopa response. And you mustn't take up patients who have dementia, uncertain diagnosis, or excessive cortical atrophy. These are the ones you need to avoid. But this does not mean that you can't take up patients like this. This would have definitely been difficult to do because this patient had a very severe camptocornea at the onset. And this is her 2 months after surgery, when you can see there's a marked reduction in the camptocornea. While this is not a usual feature, these unusual results enthuse you to take up more and more difficult cases to do this. This is the patient. Now, where did this multi country Delphi panel approach come to? When do you take up these patients? It came up from the Antonini group where they took up about 15 patients, 15 experts in the European countries. And what did they actually develop this? Well, they found that the three most important criteria are 2 hours of the waking day in off symptoms, at least 1 hour a day with troublesome dyskinesia, or 5 times oral levodopa doses per day. So you need only one of these three criteria. And you need only one of these three criteria to include the patient. And others are not so important for this thing. So why has this become important to us as movement disorder specialists is that over the last 20 plus years, we keep telling advanced Parkinson's disease, but we have not given definite goalposts for the patients which need to undergo DPS. The neurologists really don't know how to do a UPDR as well. And so it's very difficult. The epileptologists have done a much better job. They have made it simple. They said 2 patients, if you get 2 seizures for 2 months and you're on 2 drugs a day, 2 drugs a month, 2 drugs a day, if you're getting more than 2 seizures in a month for more than 2 months in a row, you should consider surgery. They have given numbers. We have actually failed to do that as a movement disorder specialist. So this criteria has become very easy to tell to the rest of the neurology crowd, including the movement disorder specialists, when we need to get DBS done. Other examples of good DBS, this lady underwent DBS in 2007, had a good life. She was making chapatis, and she actually got her sister-in-law also operated, who's the other lady in that making chapatis. Both of them are actually undergone DBS. And she's jogging. Here she was actually cycling a year back. And even now she teaches in French for 4 hours a day, 17 years after undergoing DBS. This lady is actually undergone DBS 20 years ago and is reading a newspaper. This is her walking in the corridor about 6 months ago. This reading newspaper is just about a month back. And this is her son, who is 42 years old, who underwent a DBS 2 months back. So you can do it in families and follow them up and see that they get better. This was the initial patient who had a lot of difficulty in undergoing DBS. This patient was 51 years old when he underwent DBS. He actually had undergone a thalamotomy in 1990, and the right side, he didn't have any tremors because of that, but his condition worsened over the year. And this should be a warning for single-sided lesions in MG focused ultrasound because the disease progresses. This guy progressed, became totally incapacitated. 14 hours a day, he'd go up and down with 3 people because of very severe akathisia. He was like a log. He was on for only half an hour in the morning, half an hour in the evening with 2 tablets. And this was the condition when he was on. He was otherwise near normal, but actually festinating very badly. And during this time that he would carry out his daily ablutions. After surgery, in December 2000, he started walking within a month independently. 2 months post-op, you can see him walking very well. And this is him 5 years later. This is him 7 years later. And this is him some 15 years later. 16 years later. He had fallen down, sustained injuries, but was still mobile. Had fractures, but was otherwise okay. He lived for 20 years after surgery, and his illness was, by the time of his death, some 50 years of his life, he had Parkinson's disease. His cognition had become worse towards the end, but on the whole, he was still mobile. What about the other therapies? What are the therapies we look at is levodopa infusion gel versus DBS versus continuous apomorphine infusion. The on time is increased maximally in DBS, and this has been seen that even after 15 months, these guys are better. Here you can see the comparison between DBS, levodopa infusion gel and continuous apomorphine infusion. DBS was ranked first for reduction in off time, while infusion of levodopa was ranked first for improvement in quality of life. And this has been seen consistently in the meta-analysis. You also get a marked reduction in the non-motor symptoms, which is seen in the form of reduction in sleep and fatigue, abnormalities in the DBS, in the radar. You can see the improvement in the urinary function. You can see the improvement in the gastrointestinal functions, all of which are much less in the other therapies. What about focused ultrasound? It is basically unilateral, so we need to see for how long the effect will last in Parkinson's disease before the final word can be said on it. Right now, what is established with long-standing large amount of data is actually DBS. So today, if you're going to do anything, it is subthalamic nucleus, which you offer stimulation bilateral DBS. Others are only experimental for bilateral focused ultrasound or even bilateral radiofrequency ablation. These are experimental, and we need many more studies before we offer this. This has been the same what we said about the criteria which I showed before. And this is the German Society Neurological Criteria, which was published in February this year, which said very clearly, follow the 5-to-1 criteria. We have patients who have motor fluctuations with or without dyskinesia. If you have a 33% improvement, you can take them up. Younger than 60 years, motor fluctuations less than 3 years, with 4 years disease, they should have a 50% improvement. And severe tremor, you can do a bilateral placement of STN DBS. And basically, if they are pharmacoresistant, do it bilaterally. Both the STN DBS and the GPI DBS can be given for medication-resistant tremor. And you can also do a WIM or bilateral DBS only for tremor. Non-motor symptoms are not currently an established indication, but they can support the consideration. And any day, the STN DBS is preferred over the GPI DBS in Parkinson's disease with motor fluctuations with or without dyskinesia. The STN DBS is superior. So, for focused ultrasound, we still have to see, because as said before, these patients can change to an equivalent time from tremor-dominant symptoms to bradykinetic symptoms or fluctuations, which will not respond to WIM ablation. Genetics is a long story, and I think time will not permit me to say this. So I will stop here and say I will skip this section because I think I'm out of time. Do I have any more time?
You can say short summary.
Hello?
Yes, Prof.
This is just to show you a patient who we operated in 2023. This is before surgery. This is her off, and this is her on. This lady did not go out of her room for 3 years because of the severe incapacitation with Parkinson's disease. She was not able to go for any social functions or for even to the market. After surgery, within a month, her symptoms got controlled. Tremor was controlled. And this is her 9 months and 6 months after surgery, getting an eventful result. Thank you. I'll stop here.
Thank you very much. That was wonderful, Professor Borgohain. Can call you Ropam. That was a beautiful, beautiful overview of the start of the STN DBS, going through the indication and tackling a few issues about how to select the patient for surgery and what difficulties we can see. I noticed few things in your presentation. You did not tackle the issue of difficulties in countries like your country that may not have enough support, financial problem having DBS. Can you tell us more about that? How can we look into DBS in a country like in South Asia, where financial issue can be a problem between DBS versus lesioning versus only medical treatment? How you look into this when you decide about DBS?
Actually, I work in the state of Andhra Pradesh, and after 15 years or so, the state government, the politicians realized that the DBS works very well, and they started giving it free to everybody. It's free. Can you beat it? And the poor patients just need to walk up to the government hospital, and we could get CMRF and do it. Even after the state split into two states, both the states are giving it free. This is for the poor patients. The richer patients, most of them have insurance, are getting insurance, or they raise the money. It's still a difficult proposition. The cheapest one is about roughly about $15,000. The cheapest one. The most expensive ones are around $25,000. So they do manage somehow to get it together and put it together. It's not easy. There are lots of poor patients, but that advantage is that because of the therapeutic benefit, we were running the biggest program in the state, the only program in the state, and the state started giving it free without us even going to the politicians or to the bureaucrats. It's amazing how they got that whiff of what's going on and how good it is. Now, this is not possible, but I think most of the states will be able to cover it if they have the advocacy groups to do this.
That's super to hear that. Super to hear that. Let me focus more about the age selection.
Yeah.
What do you see about age selection? You have no problem calling it below 70 and after 70. You don't have like a cutoff where you say surgery is a no-no. I've seen you operating on 83.
Yes, we have 83, 84. We look for one that their brain is we get the MRI brain, look at the structure of the brain. If it's fair to go, we go ahead. We look at two, the cognition. How good is the cognition? And if it's possible to do, we do. What we do avoid is if he's got moderate dementia. Moderate to severe dementia, we say it's not worth doing, we do not do. That's about the only criteria which stops us. Now, the chances of hemorrhage has come down remarkably because we have actually reduced the microelectrodes from 5 to 3, and we are actually doing it much faster. The targeting has got much better. The imageology has got much better. The hemorrhages are the biggest inhibition, but they have also come down remarkably because of these measures. We do the pre-op MRI, use it with the CT and the fiducial so that we are able to avoid the blood vessels to a large extent. We do the coagulation workup and try to avoid major problems.
That's super. I can see that someone is asking for a question. Olomamiel Opera raised his hand. Please, can you join us and see what question you have?
Okay, thank you very much, Prof. Can you hear me?
Yes.
Yes, we can hear you very well.
Wonderful. Thank you. Thank you, Prof, for your great presentation. It's really very exciting to see it happening in your place. And I thank you for the question you asked about how do we do it for poor people. I'm happy that in your place, the service is free for poor people. I just want to ask, in my own country, I'm also from an LMIC. The MRIs we have are 1.5 Tesla MRIs. I want to find out, can we do DBS with a 1.5 Tesla MRI?
Yeah, you can do. We are doing most of the time with the 1.5 Tesla only.
Wonderful.
See, one thing is there. If you're going to be part of the neurology group, you need to be able to plan on the MRI, which is not very difficult. We can plan on the MRI console and match whatever the patient, whatever the surgeon is doing. The surgeon will use more sophisticated soft hardware actually. Most of it is actually the brain lab or whatever you use, he will be fusing the image. So fusion has an error of about 1 millimeter or so. If you can plan simultaneously on the MRI, which is the direct image, and there is no fusion, you can cross-match what he is doing. The other advantage that we use for programming, which is actually not mentioned in the textbooks, is that the 4 contacts that you have are 1.5 millimeters each. The intercontact distance is 0.5 millimeters. So if you take MRI slices which are 2 millimeters thick with 0 interslice interval, each slice will be roughly representing a contact. So if you know your anatomy, post-op, you can actually look at this and do your post-op programming. It becomes much easier. This is one market advantage for programming. You don't need to have other sophisticated or look for a fusion image later on. Programming is the big bugbear as far as neurologists is concerned, and that we need to spend some time in the STN DBS, but you can get it done. Third thing is managing the medications. The medications also, you should be able to get a handle. Look at the ones where you need to look at the dyskinesias. And I had done the original work in sulfonamide, so that sulfonamide also works well as an anti-dyskinetic agent if you go up to 150 and sometimes even up to 200. Along with amantadine, they help take care of the dyskinesias. So these are things which you can use for programming.
Excellent. I have a couple of questions from Dr. Harshat Parekh, and I'm just going to select one of the question. Change of battery after how many years? So what's your strategy of selecting batteries or going through rechargeable battery? I want to hear your opinion about that.
Frankly, we were always using a 5-year battery before the rechargeables came in. The 5-year batteries, the main thing was people were saying, and not me, the people who were driving the program in more affluent countries, hike up the current, take off the medicines. For me, that was a no-no because in medicines in India are cheap. The battery is expensive. So we used to go low current and low meds. And that today is considered the optimal strategy. More you hike up the current, we have other adverse events. The lesser the medicines you use, we have less side effects from medicines. So if you merge a low current, low medicine strategy, that's the best. 5-year batteries are much cheaper, but you have to replace it after 5 years. If you're getting somewhere that they are replacing it like we have, it's easy. We can do the sophisticated implantation in our corporate hospital now and tell them to go to the government hospital and get the battery changed after 5 years. But if you don't have that access, you should go for a rechargeable battery. And that is the best way now because you can drive it for 15 to 20 years, which is not bad. Basic idea is to get them to do it early and keep them functional. Our basic treatment of Parkinson's disease by the neurologist is we kick the can down the road. We go from 3 tablets to 4 tablets to 10 to 12 tablets, add a second drug, a third drug, a fourth drug. That's not what's required because all of that will cause more confusion, more hallucinations, more RBD. What we need is to get the patient functional and keep him functional as long as possible. So once the 5-to-1 criteria is reached, once you have a fair degree of impairment, the DBS should be done early. We can keep them functional for a much longer time if we do it. That's what we are trying to do.
So you are now more in favor of keeping the patient functional in their own job, in his own lifestyle, and even if that would mean doing the surgery earlier, rather to keep him only independent. No, you advocate for being functional, going to his job, doing his work, earning his income with the help of DBS.
I have surgeons who are operating.
With the DBS working.
Yes, after DBS, they're operating, they're carrying on their lives, being productive members of society. That's what we need. We need to be much more stronger proponents for the DBS so that it's a real miracle cure.
Definitely, I do like to hear that. Well, I'm just going to see if there's any other question. Any of the participants would like to ask any question, please don't hesitate to raise your hand and contribute. I'm going to go here to question and answer. I don't have anyone open now. So maybe we are reaching to a conclusion. It was an awesome scientific session. I'm very glad that we have Professor Rupam Borogohain. He's the head of neurology and a former professor from High Tech City, Hyderabad. We really enjoyed his presentation. It was quite thorough, quite scientific in his approach, very objective in how he looked into the data. And I'm very happy that in his state, in his area, DBS is utilized in a fairly very well fashion, and it's common and reachable to ordinary people. Well, Raja, thank you very much. I will give you the microphone, and you can go ahead with the rest of the scientific program.
Well, thank you very much. It was really interesting, and I'm extremely grateful to Prof. Rupam and Prof. Alkhani for this wonderful session on STN DBS for Parkinsonism. Dr. Liu, would you like to say something, or do you have any questions before we move on?
Yeah, sorry, Prof. Just a short question, Professor. I want to know from your experience. You mentioned in your slide regarding neuromodulation. So after 30 years, is there any evidence to show that neuromodulation does happen, either through the functional imaging or a biological marker, or even the stimulation device, the frequency or such, whether any evidence to suggest that? And in cases of failure, what do you think likely, if you have any, that doesn't as expected outcome, what is the likelihood? Last question, Professor. There's so many configuration of the lead for a small fixed structure. Why does this happen? Thank you, Professor.
Okay, let me start with the last question. Why so many configurations? I think that's more marketing than use. Frankly, if you ask me, you get the standard electrode in the right place, you don't need anything else. The rest of it is mainly marketing. If you're a little off, they will try, you can, direct the current that way. But if you are actually proper in your placement, you don't need all this. In fact, most of the directional leads are used as ring electrodes in the world. Very few, a very small percentage of them are actually used for directing the current. That's one. Second, I didn't get your first question, whether it's a neuromodulation. What's the long-term outcome?
Yeah. And any evidence to suggest?
There is evidence for in the animal model. In the animal, that actually it does decrease the rate of neurodegeneration in animal models. This is not there in humans. But what we do know in humans is that they live longer, the complications are later. That's for sure. The living longer is still not 100% established, but the late development of complications, as I told you, dementia, falls, are later. Number 3 is that when the battery goes off, the patient collapses. That's why we cannot claim that we are actually changing the outcome of the disease. If the battery dies down, the patient can actually end up in a very pitiable condition. You put the battery up and he's up and running. That's remarkable about this therapy. And this can happen much later also. And we had one more question, no?
Failure case.
Failure case? The failure is basically you are not good at your targeting. Your team is not very meticulous in the way they do the thing. You're going to fail. Your main thing is getting the electrode in the right place. You're off by a millimeter, you may get suboptimal results. As far as you're concerned, the patient on the whole is going to have much less results. More than 2 millimeters away, it's not going to work. So you need to be very meticulous, very thorough. As a team, the main driver is the neurosurgeon, but the main conductor is the neurologist. They better have a good chemistry and get that job done well. That's the main thing. But in spite of getting a good placement, very few patients can develop gait problems, which we can now monitor and actually manipulate the frequency from 90 to 150 hertz. And that helps. We can have other complications like delayed edema and all that. And we've recently published long-standing DBS can actually develop NPH in certain patients. So that's just the first time described in the world. 15 years, 20 years later, they're developing NPH. Some of the complications they develop later, like gait problems, like cognition, can be treatable by treating the NPH. So we need not say that it's all progression of the disease, but other complications. So we need to keep our minds open, still get them better, and still keep them functioning.
Thank you, Professor.
Welcome. One more thing I wanted to say, I forgot,
Yes,
is
Prof.
that we tell all our patients early on, please take your medical insurance or get your medical insurance done so that when you need the money, later on you have money. That's the other thing we tell them.
Right. Well, thank you. It was a very informative and very wonderful lecture we had from Prof. Rupam, and I'm extremely grateful to him. I would like to Also mention to our viewers that this is being broadcasted on WeChat, YouTube and Zoom all over the world, and usually we get updates from Prof. Shubin about the number, but it is a 5-day long holiday due to May Day celebrations in China, so we'll soon get back to the real numbers as soon as we can. So Prof. Rupam, thank you very much, and Prof. Alkhani, extremely grateful for sharing. So we'll move on to the second session. Our very honorable Prof. Shlomi Konstantini has joined us from Israel, and we are extremely grateful to Prof. Shlomi for chipping in today. Prof. Shlomi, all yours, please.
Thank you very much, Dr. Raja. Do you see my slides?
Yes, we can see that.
You hear me. So, first of all, my admiration to you, Dr. Raja, Dr. Lu, and Professor Kato for your really ongoing dedication to neurosurgery education. You're so robust in what you do, and I know to admire the hard work behind it. So we're shifting gears into pediatrics first, and pediatric neuro-oncology, and I suggested today to speak about ependymomas. I'm representing here not only my center, my country, Dana Children's Hospital, but I'm also representing the ISPN, the International Society of Pediatric Neurosurgery, and specifically the ISPN Library. The ISPN Library started about a year and a half back. The ISPN Library is cooperating very nicely with the ACNS to spread more education. This is the website, ispnlibrary.org, and when you hit it, you'll get this window, and if you log in, it's a very simple and free login for everybody, and after you log in, you'll have full access for everything, just for everything which is in the library. At the moment, there are over 1,000 items within the library. So you can put a word, for example, if you put ependymomas, you can refine your search between presentations, meetings, articles, and videos. If you don't refine, for example, for ependymoma, you get a list. This would be thumbnails, similar to YouTube, or you can see it as a list. It's a little bit more condensed. And if you want to focus, for example, on operative videos, you'll see the relevant operative videos for the word you're searching. So, first of all, credit to the St. Jude group. These people on the slide have contributed tremendously to the way we understand pediatric ependymomas today. So, ependymomas come from the ependymal cells of the ventricles and the central canal of the spinal cord. It's about 5% of pediatric CNS tumors. 60% are in the posterior fossa, and 40% are elsewhere, mostly in the supratentorial area. About 4 out of 5 will be below the age of 8, and 1 in 3 will be below the age of 3. So in imaging, supratentorial ependymomas may resemble pilocytic astrocytomas. It can have a solid part, it can have a cystic part. The cystic part occasionally can be very good, very big, but the solid part can be also very big. And in the posterior fossa, this is how it looks. It goes down, typically below the foramen magnum, and to the side, it goes into the Luschka and may engulf the basilar and vertebral artery and even cross to the contralateral side. So this would be a right CPA angle ependymoma. You see it even sending a little foot into the CPA, but impinging on the brainstem. This would be a cerebellomedullary junction ependymoma going all the way down to C1. So the differential diagnosis in the posterior fossa would be medulloblastoma, JPAs, and epidermoid, and in the supratentorial area, it could be other gliomas, choroid plexus tumors, or pilocytic PXAs. So this would be the view many times when you open. And if you look at the historical overview, I have to make a confession that before we started to irradiate posterior fossa routinely, I lost all my infants with ependymomas. The progression-free survival was very, very low. So it took us time to acknowledge that ependymomas are radiation sensitive. The morbidity of irradiating the posterior fossa is apparently extremely low. So ependymomas are probably the only remaining pediatric brain tumor where GTR, gross total resection, is the only acceptable standard. All other tumors have other treatments that can help in curing the situation, but not in ependymomas, which makes it a very surgical disease. So we have grade 1, the subependymomas and the myxopapillary ependymomas. We have grade 2, which would be the classical ependymomas. Grade 3 would be the anaplastic ependymomas, and grade 4 would be the ependymoblastomas. This is a paper from 14 years ago. We started to acknowledge that in the posterior fossa, we have two groups, Group A, which are not doing very well, and Group B, which are doing very well. So in this specific study, and you see here, it's a multi-center study from the best centers around the world, the difference between grade 2 and grade 3 did not make a statistical significance on progression-free survival. And we started to see the molecular biology with NEL2 and LAMA2 in this study. So the WHO classification, this is from 4 years ago, ended up with 10 different categories of ependymomas. And we started to acknowledge, and this is already a couple of years, that the ependymomas in the posterior fossa and in the supratentorial and in the spine are not the same ependymomas. We shifted gears into 9 molecular subtypes. So basically, there are 3 subtypes in the spine, 3 in the posterior fossa, and 3 in the supratentorial area. We started to acknowledge that in the supratentorial area, the YAP1 and the RELA are important. Look at the progression-free survival, and you see that some of the groups do very well. For example, the supratentorial YAP1 group are doing very well. So perhaps in these groups, we can reduce the toxicity of the treatment. And this is another slide I put up on infants, 153 infants from St. Jude below the age of 3 years, just to stress that late recurrences do occur. So if you have 3 or 4 or 5 years clean, it doesn't mean that the tumor will not recur later in the course of the disease. And if you do unilateral univariate analysis, you see that extent of resection is probably the most important variable in survival and progression-free survival. This is a site from Michael Taylor from 14 years ago. No chemotherapy regimen has prolonged overall survival in children with ependymomas. This statement is still valid, and we've tried it as an adjunct to radiation therapy to improve the rate of GTR or to avoid radiation therapy in infants. It just doesn't work. So we ended up in the supratentorial area with the RELA and with the YAP, and in the infratentorial area, we've ended up with Group 1, Group A, and Group B. Other molecular markers have emerged. They're not as important today, just to show you the ZFTA and the SHIP have been also mentioned in the context of ependymoma. So what are the prognostic factors with the age? There's no clear cutoff. Generally worse prognosis for toddlers. The extent of resection, very dominant as a prognostic factor. The location also, there's a big difference between the tumors that are infiltrative into the lower cranial nerves. Radiotherapy makes a huge difference. Molecular profiling, as we have just mentioned as well. So the current general consensus is that outside clinical trials, treatment decisions should not be based on the grading. Supratentorial and posterior fossa ependymomas are different diseases, and molecular subgrouping should be part of every clinical trial that we are doing. Look at these groups. For example, look at the YAP1 supratentorial. They're doing exceedingly well. So perhaps with this group, we can avoid radiotherapy and follow, but the rest would enjoy radiotherapy. So this is, again, an example of using molecular biology in order to determine adjunct oncological treatment after resection. So this is the posterior fossa group A. These ones are based on genetic testing. This is mostly loss of chromosome 6q and gain of chromosome 1q. And you see here the Kaplan-Meier of progression-free survival. And you see when you have both the gain and the loss of these chromosomes, you're not going to do well. So the standard of care for ependymomas above the age of 1 year would be after gross total resection, conformal radiotherapy to the posterior fossa only, under 18 months 54 gray, and above 18 months 59 gray. No role for chemotherapy. If you have performed a subtotal resection, go in for a second look surgery and only then irradiate. For babies below 1 year of age, if gross total resection, you may consider chemotherapy, never been proven. No role for radiotherapy at this little age. You wait. If the tumor comes back, you re-resect, and then you apply local posterior fossa radiotherapy. Surgical tip. This is a very challenging operation, so it would be very nice to have an experienced surgeon and perhaps two experienced surgeons when you work face down. I really love to work in four hands. Use neuromonitoring. With neuromonitoring, you check the long tract and the cranial nerves, both EMG and BERA. Aim for aggressive resection while minimizing cranial nerve and vascular injury. The arachnoidal plane may not always be present between the tumor and the brain. Avoid excessive removal of microtumor flakes from the cranial nerve periphery. Second look surgery in case of residual disease. And do an immediate post-operative MRI so that you can evaluate how much you have removed. GTR is defined by combination of surgical impression and a clean MRI. Surgery is crucial. GTR is the goal with second look surgery if there is residual. After posterior fossa, you complete radiotherapy. For supratentorial tumors, you can decide based on the molecular treatment. Chemotherapy, not established. Now, here are some dilemmas. If you feel in trouble, abort the surgery and plan a second look. The same if you're not sure about the pathology during the surgery. We know that frozen section can be very misleading. Now, consider temporal tracheostomy for those who had already cranial nerve problems before the surgery. Align expectations with parents preoperatively, especially about the issue of tracheostomy and gastrostomy. Manage recurrences. Local failure is common. Consider re-resection and re-irradiation. For multiple sites, we usually provide craniospinal irradiation. Here are some examples. This is a 2-year-old. Look at this unbelievable bilateral tumor. Actually, a circle around the entire brainstem. Can you remove it? Is it possible to remove it? Is GTR possible? It is probably possible in one or two approaches, but the price may be a tracheostomy. I do not have a good experience with bilateral damage to the cranial, to the low cranial nerves. With unilateral damage, even if you have to apply tracheostomy, most of them will be able to wean it. Look at this. This is post-operative clean, but this child needed a tracheostomy. And look at this child. I will show you this child later. This is the preoperative MRI. Look at the squeezed brainstem by this monster going all the way on the right side. This is after resection. And you see there is this little piece that was left behind very anteriorly. Should you chase it before you apply radiotherapy? The answer is probably yes. You should probably do a second look, remove that piece from the same side or from the other side before you apply radiotherapy to the posterior fossa. Protons versus photons. Well, the protons seem to spare the frontal and temporal lobes better. There's low claim of more efficacy for protons, but perhaps more safety. What if molecular data is unavailable? What if monitoring is unavailable? I want to show you a few of my pearls. This girl, for example, she's a star. In my talk on DID, delay in diagnosis, she was 6 times in the emergency room of 3 leading hospitals, including barium enema because of recurrent vomiting. Had a huge ependymoma, recovered. This is how she is now. This boy, he's a Russian boy. He had a removal of a posterior fossa ependymoma in Genoa, in Italy. They left a piece in the medulla. We removed that piece, and here he is. He looks a little bit like Harry Potter. And last week in my clinic, he's a great kid. And this one really took about 10 days to wean him off the tube. I actually urged my intensivist to put a tracheostomy, but they said, no, let's wait. He fully recovered. He has his band now. He's deaf on one ear, but he's fully functional, and he loves music. And this one, this little chicken, she also was on a ventilator and then with a tube about a week, then recovered slowly, and she's fantastic. So we have an international department back in Tel Aviv. I think many of you know it. All our beautiful fellows, really beautiful fellows from all over the world. So I hope you finish and come to visit us in Tel Aviv. Thank you very much.
Thank you very much, Prof. Shlomi. It was really wonderful, and we learned a lot today. Regarding the $1 million question is like, what is the price you pay for chasing the ependymoma to the level of near total resection? In a posterior fossa ependymoma, can you give some tips how you can see it on a pre-op MRI, whether it is stuck to the brainstem or there is a plane or not?
Yeah, of course, you're right. This is the $1 million. There are 2 places that become very relevant with regard to how much to push your limit. One is the invasion into the medulla that many times occurs at the level of the obex. From my experience, it is separable from the obex and it's removable. The other piece which may give you trouble are the invaded low cranial nerves. So for the invasion, I once asked Tom Merchant, if I leave some little flecks on the capsule of nerve 910, is it still considered GTR? He said yes. So I would not cut the nerve or injure the nerve purposefully. If you just peel it off the nerve, even if you have tiny pieces on the capsule of the nerve, I would leave it. You will not see it on MRI, on a postoperative MRI. You know that you have left micro spicules, but anything which is visible on the MRI should be chased, because if you irradiate on existing disease, the tumor will come back 100% of the time.
Thank you very much. Another very intriguing question is always this clinical scenario where these children present to the emergency with acute hydrocephalus, and we are not able to operate them immediately. So what do you suggest, EVD versus shunt? What is your preferred option?
Yeah, this of course depends on the setup, and every hospital, every country has a different setup. For example, a colleague from Egypt once told me that he never does an EVD because 100% of his EVDs get infected. For us, where we have no limitations in operative room time, I would put an perioperative EVD and then try to wean it. If you don't have availability of an operation, you can do either an EVD or a shunt or an ETV, depending on your setup and on the anatomy.
Thank you very much. Any questions from my co-host, Dr. Liu Singh?
Yeah, thanks, Professor, for updating us on ependymoma. I have two questions, Professor. In your practice, do you still use the term low-grade tumor and high-grade tumor in pediatric in relation to their survival, progression-free, and also cure probably, and the treatment modality that you're going to offer, especially when we try to compare between ependymoma to medulloblastoma? They are totally different grade. And my second question, Professor, do you advocate the use of fluorescence, using fluorescent guided surgery in ependymoma? Thank you, Professor.
Thank you very much. So with regard to the fluorescein, you usually don't need it for the ependymomas. They have a different color. So it's relatively easy to differentiate between them and the normal brain. So they're different from the invasive gliomas, where sometimes you say, is it brain, is it tumor? So I don't think you need 5-ALA, by the way, is not effective, and fluorescein, you just don't need it. With regard to malignancy, yes, especially the group B in the posterior fossa, when you have changes in chromosome 1, chromosome 6, some of them do very bad, but we don't lose all of them. So even with the bad tumors, we try to get the GTR, and if there is a residual, we chase the residual, and then we apply radiotherapy to the posterior fossa. In the occurrence, which is very rare, of metastatic disease upon presentation, very, very rare, then I think you may consider being more conservative because it's very difficult to cure them, and they would need a craniospinal irradiation similar to medulloblastomas. But in medulloblastomas, I feel surgery is overrated in general. It's a very malignant disease, where in ependymomas, surgery is the primary tool to treat those children.
Thank you very much, Professor.
Thank you very much. So with that, we come to the concluding part of this webinar. I don't think there are any further questions in the chat box. Yes, someone in the attendance wants to ask something. Yes, you can ask, Dr. Ronke. You are allowed to talk.
Thank you so much, Prof, for your presentation. I really liked it. So where I practice, it's not so easy to get radiotherapy. We usually have
Where do you practice, Dr. Ronke?
In Nigeria.
Okay, fine.
So we usually have to maybe book, and the centers for radiotherapy are like really limited. I wanted to ask what your advice would be with progressing ahead with surgery when you know that you might not be able to follow with radiotherapy.
Yeah, this is a very difficult question, and actually, right at the moment, in my department, we have 2 people from Ethiopia and one wonderful colleague from Nigeria. You may know her, Mayo Para. And
yes, sir.
There are some tumors that cannot be cured without radiotherapy. And I think a posterior fossa ependymoma in an infant cannot be cured. So you ask yourself the question, should you operate at all, right? Should you operate at all if you cannot offer the post-operative care? And this is really, I don't have a black and white answer to this. And I really hope that oncological therapy in general and radiotherapy in particular in Africa will go up and up in the next decade. This is a real important goal.
Thank you so much.
Thank you. Yes, Dr. Opara.
Okay, thank you very much. Professor Shlomi, this is me, Opara here. I couldn't resist the urge to to speak when you mentioned. I just finished a 1 month rotation with Professor Shlomi in Israel, and it was a wonderful time. And just like Dr. Ronke has mentioned, yes, we do have challenges in our environment with regards to getting radiotherapy. But I also wanted to find out, Prof, just like you mentioned for medulloblastomas, in the situation where we have patients with this kind of huge tumors, and we have limitations with getting microscopes, getting a GTR, intraoperative neuromonitoring, will it be okay to go ahead to remove as much as you can and still send for radiotherapy for those who you'll be able to get radiotherapy treatment for? Thank you, Prof.
Yeah, so Alpara has prepared a fantastic talk just last week on the importance of extent of resection in medulloblastomas, and it's a totally different ball game between medulloblastomas and ependymomas. And you know, May, that in medulloblastomas, me personally, I think that surgery is overrated. And if you don't have the surgical tools, I think it is very legitimate to do a minimal surgery, a shunt, but then you have to apply some oncological therapy or just lose the child. In ependymoma, there is no way to go around the surgery. So very difficult to treat a child with ependymoma if you don't have the minimal surgical tools. I think if you have good hands and experience, you can work without monitoring, but you cannot do it without a microscope. There's no way. So maybe not do it all, as painful as it is. These are very difficult decisions, and they have to be tailored place by place, family by family, but they may be very difficult to tackle.
Thank you very much, Prof.
Well, these are questions that are beyond the realm of textbooks, and you need to tailor it with your experience and wisdom and need at your place. So thank you very much. We had a very interesting discussion. So this is closing time, and I'll close this officially on behalf of the Education Committee of the ACNS and the President Prof. Yoko Kato. I'd like to thank both speakers of today, Professor Rupam Borgohain and Prof. Shlomi Constantini, as well as Chair Prof. Ahmad Al-Khani for the time and support for the ACNS webinars. Very special thanks to my co-host Lubun Singh for joining me today. So until we all meet tomorrow online, it is bye-bye from all of us. Thank you very much for joining.